Hi, I want to thank all of you for joining our session this evening. April is Sexual Assault Awareness Month, which makes this a timely topic. In part one, we discuss signs for detecting sexual trauma, human trafficking, SANE certification, the examination process for survivors, trauma-informed care, and how to be advocates for survivors. Today, we'll delve more deeply into a few topics that were requested after the first panel. So first, we're going to start the discussion talking about the SANE process. So this is a question for Heather. Can you explain the difference between report, non-report, but collect evidence, and getting services when it comes to taking care of adults?
Sure. So there's two different ways to look at a SANE exam. You can report, which means that you gather your information from the patient, you complete a rape sexual assault kit, often with swab testing, and then that is reported over to law enforcement. In my facilities, law enforcement will come right over to us and pick up the kit. Sometimes it involves waiting a day or so for law enforcement to get to us if they don't stay for the exam, but that's called a report, where it is reported to law enforcement. Then there's other situations which are called a non-report, and that is where a patient may decide, you know, I still want to get all of the information collected for what has happened, but I'm not ready to report that for a multitude of reasons. It could be because it's a situation of maybe intimate partner violence, she's afraid, or he's afraid, or they're afraid of just what will happen if they're reported. Will they be a victim again? What does that look like for them? So there are times where patients have the decision to decide, collect all the evidence, hold on to it, and there's not a time limit. The patient can decide at any time whether or not they want to come back and have that information reported. And then in terms of getting services for adults, most of the time you're going to find that with rape sexual assault centers, at least in our area here in Georgia. Oftentimes patients will go right through the emergency rooms, and sometimes you can get services in certain hospitals, absolutely. But oftentimes they will even dispatch you to different local rape crisis centers for adults.
And so by services, we're talking about HIV, STI treatment and prophylaxis, pregnancy prevention, and just overall general kind of considerations after an exam, after a sexual assault. So they can still receive those services. So for Stacy, is this the same process for children?
The process is very different for children because, as mandated reporters, if we, encounter a crime against a child, and sexual assault would be a crime against a child, we have to report to law enforcement. At children's advocacy centers, we work as part of a multidisciplinary team, in which case Child Protective Services is part of that team, law enforcement is part of that team, the district attorney, our medical staff, and our therapy team. So when a patient comes to us, they have a full array of services provided to them. When it comes to a kit versus a non-kit, it definitely depends on time frame. If it is a peds or adolescent, that it is an acute case and we're within time frames, kits are collected. I think of the consent for collection of evidence as kind of a two-step process. If they're under the age of 14, it's usually consult with parents first, make sure that I have the parents' consent to go ahead and collect evidence. And then it becomes the child's decision after. So if the parent consents, that's great, but it's really up to the child when we are, in the medical room and we are conducting our examination on the patient. We only do what is comfortable for the patient. You always have to consider that the level of harm that could be endured. So you don't ever want to do anything or act in a certain way that would prevent the child from feeling comfortable or feeling safe, because that is essentially just giving them secondary trauma. So two levels of consent is kind of how I view it. And anyone over the age of 14 can consent on their own for their kit collection. The parents' consent is not needed at that point. And then as far as services go, yes, if it's an acute case and there are an adolescent, you would do all of the same essentially that you would do for an adult patient as far as, HIV prophylaxis, the same type of testing, the same type of STD prophylaxis medications and pregnancy prevention. If they are under the age of 14 or prepubescent, we might collect the testing, but we wouldn't necessarily, initiate treatment unless anything came back as positive.
Thank you. So the next thing we're going to go to is talking about trauma. So if Erin could answer, what are some of the non-physical signs of trauma among children?
Yeah, so this is actually really important because 97% of non-acute cases do not have any physical findings associated with their exam. And that number is about 88, 87%, even in acute exams. So that's to say that even when you see a child that's within the window of evidence collection, which would be, 120 hours, give or take, the likelihood of finding injury is pretty slim. So we like to teach people about what the non-physical signs of trauma can be, especially because there's a lot of myths out there. So for younger children, they typically experience separation anxiety. They can be overly affectionate. They can have inappropriate attachment to strangers. They can suffer from nightmares and night terrors. They might have a change in their appetite. There's a big myth that bedwetting would mean that a child has been touched inappropriately, which bedwetting by itself is not indicative that a child has been touched. Children just regress sometimes. A side note of bedwetting, though, is that function in their body is typically rooted in control issues, and control issues are usually rooted in a safety issue. So a child may be experiencing bedwetting because they're feeling unsafe for some reason, but bedwetting by itself does not indicate that a child has been touched. Curiosity about other children, meaning that if they're touching another child, it means that they themselves were touched, is also not an indicator that they were abused. Past abuse is also not an indication that somebody will become an abuser. In like the elementary school age, I would say anxiety, acting out, fearful, especially of the people that were touching them. Now, keeping in mind that about 70% of abusers are someone that they know and love and trust, that might be a sudden change. Somebody was comfortable around their uncle and now they're afraid and don't want to be near their uncle. That's just something to keep a lookout for. Difficulty sleeping and concentrating in school, poor school performance, suddenly, declining grades and focus in school is a big indicator that something's going on. But also on the other side of that, perfectionism. Some children are really manifesting that worth issue. So they might start feeling like they have to perform in order to have value, which is directly connected to the abuse that they suffered. And in older children, I would say depression, withdrawal, eating disorders, self-injurious behavior, suicidal ideation, substance abuse, risky sexual behavior. Again, that's really when you see the manifestation of those, they're starting to develop roots in their worth issues. So I must do things with my body to earn love. I will have a little note here that sometimes there can be no signs at all, or the changes are so slight that people don't really notice them. Every child is different. So there's not, a strict manual for how children are going to present. And I think it's important that we look for signs that are changes for a child's individual personality and explore that on a regular basis, but not pick one thing as the formula for jumping to conclusions, especially with kids.
Where is my lollipop board?
And as far as the second part of the question.
Hold on. Betty can get it for you. It's in the cupboard.
And my lollipop.
Go ahead, Becca, sorry.
Oh, no problem. So looking at trauma, especially if people are not wanting to talk about it, or they're not feeling comfortable with talking about it, there's a couple of ways that we can assess and ascertain if something has happened, some traumatic experience has happened to the person. So from a psychiatric nurse practitioner's perspective, a lot of times people are not coming to me because they've experienced trauma. They're coming to me for the effects of it: depression, anxiety, sadness, crying episodes, suicidal thoughts, things of that nature. So when I am doing an assessment or evaluation, this is what I, in the beginning, asking, have you ever had a traumatic experience? most of the time, people would say no. Going back and restating the question a little bit differently, have you ever had an experience that you felt like has kind of changed the way you perceive things, has really stayed with you for a long period of time, that just felt really, really uncomfortable, that made you, have any symptoms? Is there anything that triggers you? Is there anything that you feel like has been any kind of like roadblock for you when it comes to your mental health and how you'd like to be? When we ask the question that way, then you get, oh, okay, this happened, this happened, this happened. People always associate trauma with, this has to be something very, very significant, very, very, well, traumatizing. They don't see things like, oh, my parents got divorced as maybe something that was traumatic, or, being bullied. I may not see that as something traumatic. So what we try to do is, when we're interviewing, ask the questions in different ways to see if we can get a different response. Just making sure that we are, well, one, knowing what kind, age range, what is age appropriate, how to ask the question. And then on the second part of that, making sure that people understand what trauma is. It doesn't always have to be some kind of abuse or neglect. It could be something else that's happened that, again, has just impacted your mental health. So what we like to do is, ask those kinds of questions, making sure that we are building trust and rapport. And they may not tell you the first time. Unless I'm in an emergency room setting, which I do consults in the ER setting, and I've already gotten report from someone else that a traumatic experience has happened. If I am in, outpatient clinic, I may not know of that because they may not, again, recognize that that was a traumatic experience. They may just say, that's just the way it was. That's the way I grew up. It was normal for people to, yell and scream in my household, or it was normal for this to happen. And sometimes people just don't catch that is a trauma. So we like to build trust and rapport. We like to make sure that we're asking questions, and we may have to kind of change our way that we ask questions depending, again, on the age range, their background. There's just certain things that when you ask certain people, again, they may not realize that that's a traumatic experience. And then if it is a child and a parent, sometimes we do have to, interview them separately. Mom or dad may have to step out so we can talk to child by themselves or teenager by themselves. There just may not be a comfort level with talking about certain things when certain people are in the room. So that may be something else that we do to make sure that we can get the full information. And again, you may not get the whole picture, the very first time you talk to them. But if you continue to see them, as I do in my practice, hopefully, as I tend to get more information. And sometimes it's just we have to be an investigator. Well, this connects to this, connects to this. This all comes back to this particular event that happened. And it may take a couple of sessions to get them to talk about that or to reveal that. So it is a little bit trickier on our side, just because, again, people aren't necessarily coming and saying, oh, this traumatic thing happened to me. This is why I'm here to talk to you today. It's usually those after effects and those negative impact of trauma that they're coming in for to be seen.
That's great. This is one reason why I appreciate us having this dialogue, because even listening to you and how you ask questions in a way that I've never thought about asking questions is really helpful. So I'll be going back and writing down some of those questions, because I think sometimes you get so used to asking questions the way that you're used to that it's like there's a different way of approaching that. So that was actually really helpful.
What I try to do is tailor it to who I'm talking to. So if I have, like, for example, I have someone that's older, I'm not going to ask them a certain, let's say a baby boomer. I'm not going to ask them the same question I would ask to someone that's in Gen Z, because they're not. There's certain things they're like, that's not trauma. That's the way we grew up. Like, what are you talking about? So I try to tailor to as much as I can to, the generation they grew up in. If I know a little bit about their background, how they were raised, things of that nature, then I can tailor what I'm going to say to ask them in the most sensitive, most appropriate way, so that they're not like clamming up or getting upset or I don't want to talk about that, or why are you asking me about that? I'm here for this. What does that have to do with anything? So, sometimes unfortunately patients can get defensive. They can get a little bit testy. So I just want to make sure that they're comfortable. We're not talking about anything that's kind of like off limits for them. So I try to tailor as much as I can.
That's great. So the next thing we're going to go to is talking a bit about consent. And so this is a question for Stacy. And so what is consent, and can children consent to sexual activity?
That's a really great question. And I think that the more we have conversations about consent, especially with younger generations, the more people will get used to that and probably incorporate that, into their, dating life and into the years as they get older, which is very important. So consent essentially is going to be an agreement between participants to engage in sexual activity. What consent isn't, I think, is extremely important, is you cannot consent if you're under the legal age. If you're intoxicated by alcohol or incapacitated by drugs, or if you are essentially asleep or unconscious. Those are times when you're not able to consent. As far as children consenting, the legal age ranges. There's 31 states in the United States that have the legal age of 16, with 18 of those actually having like it is called an exemption clause. It's a close age proximity clause. Some of them will range between like a 13-year-old can consent to sexual activity with another individual as long as they are no more than maybe 3 or 4 years older than them. So it puts them somewhere between, you know, with a 16-year-old or a 17-year-old. There's 8 states that have the legal age of 17. One I thought that was interesting in researching this was New Mexico. An 18-year-old can have a consensual relationship with someone who's under the age of 17 as long as it's no more than 4 years. So a 14-year-old and an 18-year-old in New Mexico is considered legal. And then 11 states have the legal age as 18, Tennessee being one of them. But their close proximity is, again, no more than 4 years. So teens between the ages of 13 and 18 have that 4-year range. So as long as if it's a 13-year-old, it's not illegal if the participant is 17. Statutory rape laws exist federally, so standard age federally is considered 16 years of age.
So bottom line is that a child cannot consent to sexual activity. I mean, if they don't have the capacity to be
with an adult. Right. Anyone that a child cannot consent to sexual activity with anyone over the age of 18, or anyone, even if they're under the age of 18, but maybe they have been put in a like a supervisor role, or somebody who's essentially in charge of them. So maybe if they go off to camp and it's like a camp counselor, but they're under the age of 18, but they're in a supervisory role of the child, that is considered illegal. A babysitter, you know, a coach or a teacher, or someone like a school nurse, anybody that's in like a health capacity role, or even if it is, you know, maybe in a hospital setting, whether it be, you know, a routine hospital or a psychiatric facility or something of that nature, anybody who's essentially supposed to be looking out for and caring for that child is never to, you know, engage in sexual activity with a child, regardless of age.
I think this may seem like an obvious question that we're discussing to many people who are listening to this webinar, but part of this came about with the discussion of working and interfacing with many times other disciplines, where language is very important about how we're framing things that happen, especially to kids, because you'll hear people talk about, well, you know, child X had sex with this person. And it's like, okay, well, if the child is 7 years old, they don't have the capacity to be able to consent to that. They don't understand it, and they are not able to do that. So I think sometimes being mindful of some of the language, that if we're hearing language that other people are using that is really kind of minimizing in some ways what may be happening to that child, it's important that we kind of speak up on, especially that child's behalf, of just really being very direct about exactly what is going on. And it's not really that they're having sex with somebody. It's much more complicated than that.
It's abuse. Yeah, that it seems to be a hard word to say sometimes, right? They want to say, oh, they had sex with a person, but you didn't. They were sexually abused by a person. That's a very different lens, and you have to view it from that lens in order to, I think, get it right for the survivor.
Yeah, great. So for Heather, what are some helpful hints on how parents can teach their children about consent?
So I feel like it's a parent's responsibility almost through each phase of a child's life to kind of be teaching these parts of consent. So kind of to reiterate what Stacy went on, it's like, you know what consent is. It's obviously become a pretty big buzzword in the wake of Me Too. And I think it's almost like this call to action of parents, and that's where it starts. And then to even engage more in the school system around it. But we really kind of start learning about it as early as preschool. Just kind of when you think about the notion of respecting others' boundaries, and in order to be safe, in order to preserve dignity, building those healthy relationships. So that's kind of where it starts in the early years. And then in the middle and the high school years, there's going to be a lot more in-depth discussions around consent. That's of course going to involve sexuality. When we think about the younger students, though, more your middle schoolers and your elementary schools, the conversation can be a little bit different. Teaching them about consent can keep them safe, like stranger danger, child predators, but also in simpler ways, such as like if you're playing a game with a child, kind of, do you want to move here? Do you want to move there? What does that look like for you? Do you want to get a hug from your classmate? Do you want Aunt Jenny to hug you? Like asking your child those questions. We shouldn't assume in those early years of life, like, hey, this family member can just come up and hug you because it's your family and you should let them, but kind of laying some of that groundwork there that it's okay to say, you know what, maybe I don't want a hug from that family member, and kind of starting to lay that groundwork. And that also helps them have a better understanding of their sexual relationships much earlier on, as well as kind of classroom environment and safer things around that. The other thing I also really talk about a lot, especially at my trafficking center, and especially when talking to the kids, is to really check in on especially younger people with their emotions. A lot of times just adults, but just our society in general, we really discourage people from showing any kind of sadness, anger, discomfort, especially for boys. Like we say, oh, you can't cry in public, or, oh, you shouldn't show your emotions, be tough. But you really want to learn to kind of identify these emotions so that they can learn how to advocate for themselves when they're hurt. And it really also helps them to develop empathy and to recognize similar emotions in other children and adults, so that when they're doing actions that may make someone feel uncomfortable, they know kind of what that looks like. And I think that all kind of goes into parental consent.
That's great. So I'm going to open this up to everybody with this question. So what are your thoughts on the role of a college or university in making sure students understand when sex is not consensual?
I can go first because I know we discussed this a little bit. From my personal experiences, I went to Vanderbilt undergrad. I was an RA as well. So kind of seeing both sides as being a student and then being resident advisor and going to like the training firsthand, like what they did. And it was interesting because I was an RA at the same time I was in grad school. So I'm learning some of these things from a psych perspective and doing this training as a resident advisor, and just thinking of my experiences in undergrad and just, you know, undergrad hookup culture, Greek life. It was just kind of, it was all normal. It wasn't anything that we saw was problematic at the time when, you know, being 18, 19, 20 years old, you know, just hearing stories of people, you know, I was engaged, you know, they had been drinking and they might have had an encounter with someone and maybe they regretted it, maybe they didn't. It was just very, very much, we didn't take it seriously, unfortunately, at that, just being that age and just not knowing like what to think about it. It was just, everyone was kind of exploring and doing whatever they did. So being a student and going through that process, seeing how pervasive it was on campus, how it wasn't really discussed or talked about. We really didn't, you know, think about these things because it was just a rite of passage. It was normal. Everyone did. Everyone was hooking up and you know, going out, partying, all those things. Being on the flip side of that, being an RA and thinking deeply into it and getting the training that, my opinion, was not really enough or substantial for us to be able to like make these decisions. Like, who do I call if I do have a student who's coming to me and is stating that this happened to them? What do I do, me being, you know, still 19, 20, 21 years old myself? We go through this training and we have these resources to refer, but at the same time, do we feel comfortable enough to do that? Do we feel confident that we're making the right decision? Do we even know, like, what do we say to them? Like, it wasn't enough. It wasn't substantial. It wasn't, to me, in my opinion, just looking back at it from a perspective of a mental health professional, it just didn't make sense. So it's like, I have the resources to know like where you should go or who you should call, but in the moment, how can I be an empathetic person? How can I listen to and understand what you're coming from? How can I not say the wrong thing as someone, again, who doesn't really know what I'm talking about and doesn't know how to approach this and maybe has never experienced it? How do I be like that first point of contact before you do get to the professionals and you do get to the people who are going to know exactly what to do and how to help you and where you should go and how to ask the appropriate questions? So it's like we're, kids leading other kids and we're all blind and don't know what we're doing. And a lot of the times the training we got wasn't really taken seriously. Kind of like, okay, we have to do it, but are we really gonna have to deal with this? No, we're probably just gonna be dealing with, drunk freshmen, or we're dealing with people smoking weed in their rooms or whatever. No one was really taking it, I guess, seriously, as far as the training goes for how we should respond to these very, very particular cases. And it's hard because it leaves a bad taste in the person's mouth if they have a negative experience when you're trying to tell you something that they've experienced and they've gone through. And you're sitting there kind of like, I think I can help. I can call someone for you. I don't know. Should I call your mom? It wasn't enough. And I think the university does have a pretty big responsibility to do some more education and providing that training, because again, we were the first line of defense when it comes to this. And I just feel like we didn't get the proper training. We had the resources, I will say that. We were told, these are the numbers, do this. This is like the steps that you should take. But no one is teaching us, like, how do I actually talk to this person as a human being so they feel comfortable, they feel safe, they feel like they're going to be protected, they feel like they're going to be believed. That part was missing. So I was just like, here are resources, make sure they go to the center and they talk to the person. But other than that, I know you can't teach people empathy, but still, it would have been nice to have more of that kind of training, like how to actually have this conversation. If you don't feel comfortable having this conversation, is there someone else, another RA or someone more senior that could have that conversation that would be able to help facilitate that? So that was my experiences, at least.
Neka, I think it's really important too that you said you had training, but it just didn't feel like it was enough, because I think that the training is important. It's just not coming from the right people from a university standpoint. So I think the intention is there, but we're missing some steps. So I recently had an experience with a college student who was disclosing to me, and she first told me she was opening up about an experience to her RA and feeling, vulnerable and trying to, get help for things that she was struggling with. And while the RA appeared to be kind of empathetic to her situation and wanting to help her, she ended up with disciplinary action for something that she did in that process. So attaching something punitive to a vulnerable disclosure is so inappropriate and should never happen. And shortly following that incident, she experienced a sexual assault, and she didn't call anybody that she should have known that she could call in that moment. So she was at a hospital by herself, didn't realize that in that moment, she didn't have to make all the decisions. She didn't have to know immediately if she wanted to press charges, if she wanted to follow through criminally, if she could collect evidence and make that decision later, which is so important for people to know. It's such an overwhelming situation, and you're dealing like from immediate post-trauma, and to not know that you don't have to make all those decisions right now. She just said, because she didn't know what to say, okay, I don't want to press charges, because she didn't know what that looked like down the road. So she missed her window to be able to collect evidence and make that. Now she could make another report later, but there's such critical things that could have happened for her that didn't, simply because she didn't feel safe enough at her school with the resources she was provided to get that guidance. And there weren't enough people that know that information. So as far as colleges and universities, having the conversation constantly and in different ways from different perspectives is important. But I think that these trainings need to be done by people like a SANE, like somebody that does this work regularly to give them the guidance of, hey, this is what we do. These are the key points that you need to know as somebody who students might come to. And even if you don't know what to do, this is how you contact me to help guide you in that direction. Because if they're just coming from a university standpoint, it can get really caught up in the legalistic nature of what they're doing. You know, were you drunk? Did you do this? Then there's kind of that subtle victim blaming that goes into there. Well, if you hadn't been drinking, then maybe you wouldn't have, you know, been at this party and this wouldn't have happened. And students are already feeling that. They're already feeling that guilt and that shame and regret. And it's really hard to undo that when, with the best of intentions, universities are trying to help them, but they're also trying to protect students by, you know, making sure this doesn't happen again. But that's not how it comes off to students. And I think that chain of command where, you know, it's starting at the top of the university and trickling down to the RAs, the RDs, their peers. I think that the training is important, but you're right. It's not taken seriously when it's coming from just like a handbook mentality of, okay, here's a number, call this. You know, nobody remembers that number in the moment. But if we have more conversations about it, if we have somebody in there that does this work every day to come at it from a different perspective, I think we can start to change the response and the narrative around it for college students.
That's a good point. And I think a couple of things also with that. The university, you know, they have a job to protect their students. On the flip side of that, they also want to protect themselves, right? So that's where a lot of these, like you said, these gray lines come in. There isn't a independent third party who's not affiliated that will be unbiased sometimes. And I think that would also be helpful. Someone who is a community, you know, a community SANE or a community whoever that's like, you know what, I have no ties to any of this. I just want to be here for you. I want to support you. I want to help you make the best decision for you. Obviously on-campus resources are great. They're there to be utilized. People should use them. But I feel like sometimes it's that fear of, okay, am I going to get in trouble? Or are people going to know about this? Are they going to be gossiping about me if I'm, you know, seen talking to this person or reporting this or going here, going there? If there is another third party that's not affiliated that would be able to have the student feel at ease. Hey, you can talk to me, and it's not going to be any type of like issue regarding, you know, your dorm or whoever you live with and things of that nature. I think that's also something to kind of keep in mind with who would be a good person to do these trainings, who would be a good person to be able to be another resource, another off-campus resource possibly.
Well, my daughter's involved in Greek life at her university. It's not Vanderbilt. And they had a mandatory training for everybody who joined the sorority that they had to go talk about consent and boundaries and relationships and everything like that. And they had some really powerful stories of when that trust was violated and the consequences of that. So it was mandatory for the sororities. It was not mandatory for the fraternities. And so they had, of course, a packed auditorium with all the sororities there, and then just a handful of people representing the fraternities. And it was just pretty shocking when she told me about this, thinking it's saying that it's only mandatory for some, but, you know, not really a big deal for others. And I think that really, from an education side, and this is Greek life, not the university, but I think that sends a really mixed message to everybody about what your role and responsibility is in terms of even being part of this and identifying it and being an advocate and knowing when to speak up to maybe your peers, saying, you know what, this is going too far, and knowing the tools of maybe intervening. So there's a lot of things that we could do to change. So the next question is talking about different populations. And so wondering if Heather, for Heather to talk to us about what issues are unique to the LGBTQI population.
So yes, there are definitely issues very specific to them. I'm just going to kind of throw out some stats for you and then just give you a little bit of information. According to the CDC, and that's where I got most of my stats, LGBTQ people experience sexual violence at similar or higher rates than straight people. 44% of lesbians and 61% of bisexual women experience rape, physical violence, or stalking by an intimate partner, compared to 35% of straight women. 26% of gay men and 37% of bisexual men experience rape, physical violence, or stalking by an intimate partner, compared to 29% of straight men. 46% of bisexual women have been raped, compared to 17% of straight women and 13% of lesbians. 22% of bisexual women have been raped by an intimate partner, compared to 9% of straight women. And 40% of gay men and 47% of bisexual men have experienced sexual violence other than rape, compared to 21% of straight men. So within the LGBTQ community and trans community and people, they do face higher risks. And they also face higher risks just in general of poverty, stigma, and marginalization. And having those risks put them at greater risk for sexual assault. They also face higher rates of hate-motivated violence, and that can often take the form as well of sexual assault. And also just kind of the way we sometimes tend to categorize LGBTQ people in society, that they're more hypersexualized, that also stigmatizes them, and it puts them more at risk, and it stigmatizes their relationships that can lead to that intimate partner violence that stems from that internalized possible homophobia and shame.
Now, we could spend a whole day talking about this next question, so we are not going to be able to cover everything, but I'm going to ask Neka and Aaron if there's any things that practitioners need to know about any kind of racial or cultural idiosyncrasies or disparities that we need to share with the group.
Definitely. I feel like a couple of things, just obviously knowing the backgrounds of whoever you're talking to, if you are able to understand cultural backgrounds and racial backgrounds and how that may play into what you end up uncovering when you are doing your assessment or your evaluation. As far as disparities go, African American community, we are less likely, unfortunately, to seek mental health services overall. When it comes to sexual assault, sexual trauma, there sometimes can be an underlying idea of keeping things in the family, very more of a collective, versus individualism. We more so look at keeping things in the family, not really talking about things, not airing out people's business, maybe talk about it in church, but we tend to want to protect our own. So if there is someone in the family or in the neighborhood that may be a molester or a rapist, things like that, someone is being touched, someone is being looked at in that way. Unfortunately, a lot of times it is underreported. And a lot of that is the fear or the shame or just the ideas of keeping things in the family and not talking to strangers, not trusting people outside the community to talk to them and not end up with, some type of punitive repercussion or consequence of it. So a lot of times we look at what are some ways to deal with this barrier. One, having providers that look like you, that helps a lot with your comfort level and being able to talk to someone and know, hey, you understand where I'm coming from. You may have the same background as me. You understand the dynamics at play here. Looking at the whole family as a unit, especially if the family is part of the reason why the person is coming in. Who is the head of the family? Is it a matriarch? Is it a grandmother? Is it a grandfather? What have they been told? What did they know? What are their ideas and their beliefs regarding these types of sensitive topics? What are the power dynamics at play that are happening as well? And as far as spirituality goes, there is a big community of African Americans that, we believe in spiritual church, things of that nature. And it may be having to pull in church leaders and pastors as well, having them be able to also be a part of the conversation, knowing, hey, if people come to you in your church and you're talking to you about these things, what are you going to do? How are you going to respond? Because you may also be the first line. You may see that person and talk to them before anyone else gets to talk to them. They may come to you as, their spiritual leader, asking questions about, something that's happened to them. Are you going to, not say anything? Are you gonna, how are you going to respond to that? How are you going to be able to, be an ally for that person? Some of the work I've done in the past has been with, I live in Texas, in Dallas, in Southern Southern Dallas, most of our community is African American, Hispanic. So we try to work with church leaders because we understand that they're always more than likely going to be the first line when it comes to mental health services. So we have sometimes conversations, meetings with big churches, mega churches in the area. We ask them, kind of what resources they need from us. What are some things that you guys have been doing as far as being able to, talk with your parishioners, and have you been able to refer them out if that's something that a pastoral counseling that you can't handle? So those are some things that I've seen that have been barriers, but those are things that we can work around if we just are able to acknowledge there are differences, there are some disparities. How can we use people in the community to be able to break down those barriers and to help decrease those disparities? Because if it's just, you talking to the person or talking to their family, unfortunately, you may not get the outcome that you want. If you're involving more people and you're able to, break down those barriers and be able to do that, it would be really helpful for the person and for anyone else who's involved too. And that also helps with the stigma of everything as well. So I think that's something that we can find that can be helpful.
And I would say too, with children, sometimes it feels like I have cultural waves, in different seasons of everybody of, Hispanic, or everybody that's African American, or everybody that's Caucasian at this time seems to be who I'm seeing. But the most important takeaway is that sexual abuse does not discriminate. It has nothing to do with your race, your ethnicity, your socioeconomic status. I have seen it in every color, every ethnicity, whether they're wealthy, whether they're poor. It is a problem no matter what. And that's the important thing, I think, that we have to remember, because you have to really check your own subconscious bias before you walk into a situation that, catches you off guard. And I would never, just as much as I would never want to project, a false allegation onto somebody, I would definitely never want to walk into a situation where I am caught off guard by the person, sitting in front of me, or by the information I'm receiving, because I really want to be open and knowledgeable about the fact that it really does not discriminate. And I think that's important, that we kind of get rid of those stigmas around it so that we can respond appropriately no matter what the situation you might be hearing the disclosure in. As far as physical exams, I would say that I always try to remember that false alarms can occur more commonly in different groups of people. For example, urethral prolapse, for some reason, tends to always be more prevalent in African American girls. Lichen sclerosis is another false alarm. It doesn't typically have a racial predisposition. There's just, I would say that Latina girls typically hit puberty a little bit earlier than other girls, but providers don't always recognize that girls look different. They just do. People in general look different down there. And especially if it's a provider that doesn't, do genital exams on a regular basis, I get the referrals from other providers telling me that they think this girl's hole is too big. And first of all, you can't say that, especially about a child, when you don't have a measurement of an appropriately sized hole to say it's either too big or too small comparatively. And by no means should you ever be measuring a child's hole. That's borderline sexually abusive in itself. But there's no such thing as a hole too big. Children look different. They hit puberty earlier than others. They have different levels of estrogenization happening at different rates. And so I think to just know you're normal and then take every situation uniquely, with trying to eliminate your biases, is what's really important as far as approaching it from a cultural standpoint.
That's a great point. So we're going to transition now into talking about some solutions with this. So if Erin and Stacy, if you guys want to talk about what resources are available for children, that would be great.
Yeah, so following assault, we have a program at our agency called COPE. It's for younger children, and it teaches them about safe and unsafe touches and body boundaries, which I think is really important, whether they've been touched or not. I think it's an important program for kids developing to learn that information. Play therapy for younger children, talk therapy when it becomes appropriate. The main point is that it needs to be trauma-based. I always want to encourage children to stay with the therapist that they're comfortable with, but maybe that means we need to add a second counseling, a second therapist that's more trauma focused, because not every therapist is equipped to deal with the trauma that they've just experienced. Sometimes they're for other things. So one therapist size does not fit all is important to remember. With the teenagers, if substance abuse is involved and there's concerns for addiction, I think it's important to remember that the addiction needs to be treated first before we can reach the underlying trauma. You do run the risk of triggering, as they're trying to address the underlying trauma and they're still substance dependent, you kind of run the risk that they end up returning to the substance to cope with the triggering of the trauma that they've experienced. So that's something that we have to kind of keep in mind when we're dealing with teenagers. Family support is paramount. So whether that's referring them for family counseling or just as a provider, being able to look at a child and say, I believe you, can make all the difference in the world. Now, again, returning back to the fact that, 70% of this abuse happens from people they know and they love and they trust. They're already afraid to disclose because of what it's going to do to their family. They're seeing the turmoil around them from the disclosure that they've made. And sometimes you have families that are telling them, well, this is a family matter, don't talk about it. Or they have a parent that is totally aligned with the abuser and not with the child. And it's hard for them to work through that. So they might not have ever heard, I believe you before. It's one of the first things I say to a child after they've disclosed to me, whether or not they've heard it. I say, I believe you and thank you for telling me. So I think it's important to really validate them in that, because I don't even know how many times that I have had a child that has looked at me and told me nobody has said that to them before. And it's really important that they hear that. As far as my physical exam for kids, I always give them the choice to have their body looked at no matter the situation. I don't tell them that it's their right to decide who touches their body and when, and then make them force them to let me touch their body. It's completely contradictory and inappropriate. And we need to instill that autonomy, but walking them through the exam, letting them know it's not going to hurt them, letting them play with the equipment, seeing what that looks like. Because on the flip side of that is just as important, because it can make all the difference in the world. Even if I don't have concerns for injury, that they know that just by looking at them, nobody can tell that anything has happened to them. So being able to have that moment to tell them that is important. And then I do affirmations with all kids and teenagers, but especially the younger ones, because I think that if we can instill, body autonomy and that foundation of worth in them at such a young age where they're just sponges and soaking everything up into their brains, then maybe we can kind of combat the worth issues that are taking root as they get older and that kind of manifest in adulthood. So children that kind of grow and develop with those seeds planted of I am strong, I am brave, I am smart, I can do anything, I love myself, those things just bloom into a healthier foundation rather than adults trying to relearn their value in the midst of their lifetime of trauma.
Yeah, I agree with Erin. I do body safety with every one of the patients. And just like she said, if you're going through an examination and a child says no, I give them a high five for that, because good for you that you were able to tell me no, that you weren't forced to think just because I'm a medical provider that I have the right to do anything. So yeah, always definitely give the options, let them know that they are in charge, because at some point the reason why they're there is because someone took their control from them. So it's really important to give that back to them. And as therapy goes, that is the most, I think, important resource that we can provide for patients and their families once they leave. So often, I think parents need the therapy just as much as kids to try to cope with what has happened to their family, to their child. The trauma-focused cognitive behavioral therapy is considered gold standard for any trauma patient, and especially sexual assault patients. It is pretty much the go-to therapy, and that incorporates family if it's age appropriate. If it's not age appropriate, or maybe they lack, the ability to communicate with their therapist, we definitely have other options. We do an equine therapy called Marley's Mission that we work really close with, which is nice. There's art therapy options as well. And as far as just overall, types of resources, is just acknowledging it, like Erin says, is just, saying, I believe you, this is a place to start. And there's always that little bit of apprehension too when they come to the center, because they don't know what to expect and they don't know, how to feel about it. So I always ask them to, well, how do you feel after coming? Do you feel better? Because that's the goal, right? Is to help them feel better being there. Talking a little bit, did you feel better after you went through your forensic interview and you were able to talk to them about the trauma that you experienced? And just going through those steps, it's just the start of that journey of healing for them that I think is so very important. It's probably the best resource we can give them.
Great. So this next question is for NECA, and it's how prominent is sexual trauma in behavioral health? So I think this kind of goes along with identification and all of that.
So that's a really great question, especially since, like I stated before, it's very rare that I'm seeing someone and they're coming in because of trauma. It's almost always something else, depression, anxiety, problem sleeping, and then we unravel the string and we learn, oh, okay, a lot of this is coming from trauma. So with that being said, with people who do have any history of any kind of sexual, with rape specifically, about 45% of women meet criteria for PTSD of those who actually even go to get services. And then the rates are a little bit low for men, about 38%. And then for people who have childhood sexual trauma, women only meet criteria, about 26% of women meet criteria for PTSD. They may be meeting criteria for other things, again, just regular generalized anxiety disorder or major depressive disorder. But for, you know, the actual trauma response, looking at PTSD, even for people who are stating, yes, this happened to me, a lot of them are not even meeting criteria to be diagnosed with PTSD. So they may be getting treated for other things, again, general anxiety, depression, problem sleeping, things of that nature. So within behavioral health, we do try to ask those questions. We do try to make sure that we are ascertaining a lot of that information. Unfortunately, a lot of times they're not wanting to talk about it. I mean, I can say in my, I don't know, 10, 11 years of practice, I've probably had maybe 5 or 6 patients who came to me specifically after a sexual assault had occurred within the past maybe 3 to 6 months. And I could not get them to see a therapist. They wouldn't go, they wouldn't do it. For different reasons. They were like, I just, you know, I want medicine. I want my symptoms to improve. I don't want to talk about that thing. I don't want to process that thing. I want my symptoms to improve. And then maybe after 6 months or a year or however long, I can feel comfortable talking about it. So it's really interesting being that person who's trying to, like, you know, hey, you know, I know back then we had a conversation about it. You really didn't want to talk to a therapist. You're really scared what's going to come out when you start to process these emotions. But now you're on medicine, you're doing better, you have a new job, you moved out, you're all these things. I just keep continuing to have that conversation. I try to bring it up at least every session, but for me, it's very rare that I'm seeing for someone who has come, you know, to be seen directly after an incident has occurred. Usually I'm figuring it out, oh, this happened, you know, 3 or 4 years ago, I had, you know, a rape, or I had, you know, from 8 to 10 years old, I was molested by my uncle. I'm finding that out during the course of the interview. That is not the reason that they're coming to see me. So just anecdotally in practice, I'm not seeing a lot of that, but, you know, the statistics are showing that it's pretty prominent in our services. It's just, again, getting them to answer the question, getting them to be able to talk about it, and then seeing if we can get them referred out to an appropriate therapist, again, who does, you know, CBT, the trauma-focused care, EMDR. There's just so many types of therapy modalities that would be really, really helpful. Again, if the person is ready to face that and talk about it. So unfortunately, my experiences, they haven't been ready to do that, but I'm at the point where I'm kind of like, well, you know, you're seeing me, you're seeing someone and you're getting treatment. I wish I could do more for you because, you know, I'm not a therapist. I want you to see a therapist because right now you feel better because you're on medication and you're doing all these things. You're back to work. You're not having panic attacks. You're not having nightmares, intrusive thoughts. But there's going to be a certain point where this has to be dealt with. I know you don't want to deal with it today. You probably don't want to deal with it tomorrow. Maybe you won't even want to deal with it next year. But I just continue to encourage them and say, hey, you know, I'm here for you at any point in time, but I am limited in what I can do for you. I really think it's good if you get in with a specialist who can really, you know, help you process and delve into these things, what happened that day. But again, a lot of it's fear. I feel good right now on my medicine. I'm sleeping, I'm doing all these things. I don't want to go back and talk about that. And I understand that. And I don't want to push, but at the same time, I just want them to get the services that they need, all of it, not just medication. So that's what I tend to see in my outpatient practice. Again, the hospital is a little bit different. I try to make sure that we have them, give them all the resources. Unfortunately, sometimes they follow up, sometimes they don't. And it's just letting them make that decision for themselves, but offering everything that I can to make sure that I'm doing my due diligence as a provider and providing that level of care.
That's terrific. So Heather, the next question is for you, and it's how can we address victim shaming in healthcare and also in society?
So I think it's really important, again, kind of a lot of the things that we've been sharing along is that like our society really does a lot of victim blaming and a lot of that in our culture and I think part of it, I think a big part of it is I was kind of just reading some articles and reading through that is a lot of the victim blaming is because we don't want to feel out of control. And so that's part of it. But a lot of people will also say, that the experts will say that a person needs to feel free to love the way that they do and be affirmed by those who can feel those feelings. So a big part of helping just with the victim shaming is making people feel validated. Seeing it when you're talking to your patients, listening to them, a big part of it that we can do in healthcare is just really being responsive to just kind of that active listening and listening to your patient and listening to what they're saying, giving them words of encouragement, validating them. And it's also really important to kind of help them find mental health and a therapist, just like like you had heard a lot of us that have talked about tonight, is to find a therapist, find someone that they're really comfortable talking about. Us as nurse practitioners, a lot of times we're not going to be that therapy piece for them. We can get them only so far, but help them find someone because it's really part of that whole biopsychosocial approach when we're dealing with a sexual assault or any kind of trauma or anything around that. It definitely takes a mental piece, a physical piece, a spiritual, all those pieces. So just kind of helping them find someone that they can really engage with and feel comfortable because it is such a personal thing for them. Other things that we can do again is just keep letting, you've heard us say it a few times tonight, but just let patients know, let the survivors know that it's not their fault. Hold abusers accountable for their actions. Don't let them make excuses. Don't let them blame the victim. Don't let them blame drugs or alcohol, especially in situations around intimate partner violence. If the patient is coming in with their partner and there's a bunch of excuses, hold both of them accountable. The victim to validate them and tell them that they're not alone, this is not okay. And the abuser, again, hold them accountable to stop making the excuses. You also want to acknowledge that survivors are going to be their own best experts and provide them with resources and the support. Remember too, especially in situations that may surround intimate partner violence, you may give them the resources and they may see you multiple times, especially if you're their primary care provider. And it may take them up to 8 to 10 times before they walk away from their partner. So those are really important to know. And then also just to recognize that victim blaming can take on many forms. So it can be rooted in things such as racism, sexism, homophobia, just a lot of the attitudes that tend to sometimes be present in society.
That's great. And I think also holding others around us, other disciplines or people within our own discipline accountable. So if they're saying things that sound as though that they're blaming the victim, that we speak up on their behalf, because I think sometimes people, they get into this pattern of, and they don't even realize that they're actually blaming the victim. It's like, well, you know, if that person wouldn't have gone out drinking that night, it never would have happened to them. And just making sure that it's like, okay, we need to really rethink about the language that you're using, talking about what happened to this person. So as usual, we have more questions than we do have time, which is a terrific problem to have in terms of getting through everything. But I do want to ask this last question because it came from one of the nursing students. And they're asking about how can nursing students get involved or get training in working with sexual assault survivors. I'm going to open this up to the group first, and then I'll have some closing thoughts.
Sure, I'll go first. So if you are interested, I suppose, in adults or pediatrics, I will let you know that you can likely obtain both of those trainings in a children's advocacy center. So if you are looking to volunteer your time, always gratefully appreciative to have extra hands aboard. And it's a very interesting environment. It's a lot different than, maybe joining part of a team in a hospital setting, because you get to see all the disciplines kind of at work. You get to see law enforcement there, you get to see child protective services, and you get to the therapists weigh in as well. So it's a very interesting environment. And like I said, you can get pediatric training while you're there, and then anyone over the age of 14 would fall underneath the adolescent adult certification. So it's a good place, I think, that you can get a lot of training all in one location. Where else? Oh, the IAFN, their website has a lot of really great information on it. I think that if you're looking to get certified, they have the training, the 40 hours there, which is an excellent program. I think, Heather, you know of a second program too, aside from the IAFN, if I'm not.
Yeah, it's the, I'm going to get it wrong, the Academy of Forensic Nursing. We've just put together a large course for it. It will have a certification that goes with it. So instead of SANE or SANE-P, you'll be like AFNC, Advanced Forensic Nurse, and then they have a generalist, GFNC, and you take a certification test, and we're also putting together certification modules for it as well. So 2 different pathways to look at. And the American Academy is going to be more on, it's not just going to be all in sexual assault. There'll be a lot of stuff in there, just like human trafficking, all the different aspects of everything. So again, 2 different ways to look at it.
And to add to what Stacy said, I mean, I work in a children's advocacy center as well, and I have so many students that come through, whether they're grad school students or undergraduate nursing students, and they follow me all the time. They get to hear disclosures, they get experience doing the exams and participating in them with me, you know, doing like lab tests and pregnancy tests and treating with prophylaxis. They come to court with me and they watch me testify. It's a cool experience for them. And even if it's not something that you want to do with your life, I think that they oftentimes take home a ton of resources in their practice where they can recognize child abuse, you know, just in whatever form of nursing that they're practicing. And I think that just having the awareness of that and knowing how to interact and not be so caught off guard when you're in a situation like that in your regular practice is really important. So I recommend doing at least 1 rotation in a situation, if it's accessible to you, just to see what it's all about and take some tools into your regular practice with you.
I think coming to like a children's advocacy center also gives nursing students, nurses in general, kind of that, what happens after I call Childline, right? You've had them in your ER, or you're a school nurse, maybe you've seen them at school, or you're a mandated reporter. So what happens next? So I think that also gives you really great perspective in that aspect.
And I think as a student, if you're wanting to get involved in your local community, you know, especially like at Vanderbilt, you've got Project Safe, you've got sexual assault centers that are out there, you know, seeing if they need help with the hotline or being trained as a patient advocate. So there's a lot of different ways in terms of, you know, working with patients, victims, survivors, whichever language is appropriate at that time. So there's a lot of different avenues. If anybody has any kind of questions specifically about SANE training, if you want to contact me, I'm more than happy to answer any questions you may have or give you more details about that. So, but I think if everybody on this webinar can also give you a lot of details about it. So I just want to thank everybody for their time this evening. We still have more things to talk about, which just, I think, speaks to the fact that this is a very complicated, very nuanced issue that there's still a lot of things that we can talk about. There's still a lot of solutions that we need to talk about, a lot of societal problems that we need to address, but at least we're having the dialogue and willing to hold this space to be able to talk about this very important issue that is happening in society. So I want to thank everybody. I want to thank all the panelists. I want to thank everybody in the alumni office for organizing this. And I hope everybody has a great evening. Thank you so much.